So it's Friday, so it's time for Poets. Some of us know that as Push Off Early, tomorrow's Saturday. But in this context, it's the Perioperative Enhancement Team. Inspired by Dr. Sol Aronson and the team at Duke, a selection of clips to get us thinking about the next steps in providing world-class perioperative care. You'll find the full lectures in our back catalogue, or join us at the upcoming Perioperative Practicum for expert discussions, business case tips, and hands-on workshops. Go to www.edpom.org and look for our international programme of perioperative practicums.
Top Med Talk.
Today we have one of our very good friends and favorite guests on Top Med Talk, Dr. Lee Fleischer. Lee's a professor and chair of anesthesiology and critical care at the University of Pennsylvania School of Medicine, and he's also the chair for the American Society of Anesthesiology Brain Health Initiative. We also have Miles Berger. He is an assistant professor in the Neuroanesthesia Division and senior fellow at the Center for Aging and Human Development, all at Duke University. Gentlemen, thank you for joining us so much.
It's a pleasure. It's interesting. When we started this patient safety initiative, and it's really a soft launch 2 years ago, and we had the meeting just in late June at the AARP.
The AARP, for our listeners,
American Association for Retired People, was started by teachers trying to get health insurance. Mm-hmm. It's now actually called AARP, and they abandoned the old name, but they have about 20 to 30 million strong in the U.S., representing the elderly, especially around medical care, and have a global brain council on how to live healthier from a brain perspective. But up until now, we've been sort of saying we've got to think about ensuring that patients recover from surgery really quite quickly. And I'm not an expert, Miles is, in this space. But one of the things we heard from the patient voice at AARP was they had brain fog. And this was Kathy, who we'll be putting up on our website. She said she was okay too. And that she's in her 70s, and nobody acknowledged that it was real. And in fact, when the article came out that quoted Miles from Kaiser Health News, it's been picked up by the Washington Post and lots of other places, that justified that what had happened was something that's sort of normal, or at least not out of the abnormal. Mm-hmm. And so she wished somebody had been able to tell her what may happen and to predict who this may happen to. And so very excited about Miles' work, both in the predicting who's at risk, which I think we need to do today. We worry about cardiac, but cardiac complications, even in high risk is less than 10%. Cognitive is 30 miles?
Yeah, 30 to 40 in the highest risk patients.
So this is the most common. So, maybe you can tell the listeners a little more about both the risk prediction and how you think this interfaces with their recovery, because I think we finally have something we may be able to do in the next 3 to 5 years.
Yeah, exactly. So I think the work of the ASA Brain Health Initiative that Lee's been leading is great, and especially bringing out some of the patient voices and forcing us to listen to our patients. I think in medicine in general, just to start a little bit broadly, we don't do great with things we don't understand. If there's a disorder that patients have and we don't understand it, it's hard for us to get our heads around it. And I think a sort of nice example to compare to POCD is depression, let's say 50 or 60 years ago, before there was Prozac, before there was SSRIs. People thought, well, these people are just lazy or there's something just wrong with them. And now we understand this is actually a disorder. There's specific neurotransmitters involved. There's specific medications we can use, specific types of talk therapy that we can use. And it's understood and appreciated that it's a quote-unquote a real thing. I think we're on the verge of the same thing with POCD.
Or the new name being...
Oh, yes, thank you. Yes, PND, perioperative neurocognitive disorders, which sort of includes the old term POCD. And
POCD was post-op
cognitive dysfunction, as well as post-operative delirium. Yeah, thank you. And delayed neurocognitive recovery as well. We're sort of getting to the point where we're developing a similar biological understanding of what these disorders are, and our hope is that that'll lead to more not only treatments for patients, but at the very minimum, understanding of what patients are going through and sort of a substantiation of their symptoms and so on, as that patient talked about.
So I'm actually curious. I asked the audience here at APOM. Now, it's a selected group, but it's a British-Australian group. And 70% said they talked to their patients about cognitive dysfunction. What percent do you think, if we asked in a U.S. audience, would say?
Oh, boy.
They discussed it pre-op?
Probably less. But, I guess it depends a little bit on, how broadly you consider someone to have talked about it. So our consent forms at Duke say something about, the risk can include, all the little stuff like airway, trauma, up to brain injury and death. Yeah. So
brain injury,
but that's very vague, right? What is brain injury? Yeah. So we, our consent form doesn't specifically say words like you might be confused, you might have trouble paying attention, you might have problems with memory. I'm sure it's less. And then there's always the question of, if somebody's really anxious, do you go over all this stuff and potentially make them more anxious, et cetera? I don't have any...
Right at the point of care,
exactly.
too. I mean, that's probably not the best.
So how far are we from getting a biomarker rather than having them draw a clock?
Yeah.
Which we don't even do now.
So tell us about what you're...
Sure. So we're working hard on it. I can't provide a specific date, but we're working hard on it, and we would have liked to have had one yesterday. But I think the issue is, in general, the brain is the least well understood organ, probably in the human body. What the brain does and how it computes all these computations that provide for our conscious experience that allow us to see and hear and understand and experience the world. We don't fully understand how that works. In a sense, if you think about the basic function of the kidneys to filter the blood or, the heart to pump the blood, we understand basically how the organ does what it does. It doesn't mean we could create a heart from carbon, oxygen, and nitrogen and hydrogen. But it means we have a pretty good understanding of how it basically does what it does. With the brain, we sort of understand that at a cellular level, but we don't really understand it at a systems level. And part of the problem is that unlike a lot of other disorders where you can just draw blood-borne markers, the brain is separated from the bloodstream by the blood-brain barrier. Although that's somewhat dysfunctional in some older adults, it's still somewhat intact, I think, to some extent, at least in everyone. And that's required us to do some somewhat novel things from what's being done in other sort of perioperative studies to try to gain insights into what's going on in the brain of patients with post-operative cognitive dysfunction. For us, that's really taken two major thrusts. One is obtaining CSF, so doing lumbar punctures to get cerebrospinal fluid. That's the fluid, of course, that bathes the brain and the spinal cord and at least gives us some integrated idea of what's going on in the brain as a whole. I tend to think of CSF biomarkers as somewhat similar to a hemoglobin A1C, where that's an integrated measure of someone's glucose control over months. CSF biomarkers are integrated measures of biochemically or cellular-wise what's going on in the brain as a whole. Of course, that doesn't tell you what's happening at the actual individual synapses or networks, but at least it gives you an overall integrated measure. Certainly in diseases like Alzheimer's disease, there's very specific biochemical changes that can be measured in the CSF that have high sensitivity and specificity for diagnosing the disorder. And so our goal is to find similar biomarkers both in the CSF, that's the first method we use. The second method we use is functional neuroimaging, functional MRI, as well as PET scans in some cases. And I think these techniques are largely complementary and provide information that the other can't provide. So CSF provides very detailed molecular and cellular data, but it doesn't give us a sort of a spatial understanding of where these things are happening in the brain. Fmri is quite good at giving us a spatial understanding of where, at least at a rough level, down to a level of, let's say, 3 cubic millimeters, where things are happening in the brain and how different brain regions are changing their activity after surgery and changing their connectivity. To Lee's question about how close are we to having a biomarker, I think the closest thing we have, and it's still early, is an Fmri biomarker. And so my colleagues and I, Dr. Joseph Matthew, who initiated much of this work and was really one of the visionaries in first applying for grants and first, imagining that we could do this, use Fmri to study postoperative cognitive function. He and Dr. Jeffrey Browndyke, who's a neuropsychologist and cognitive neuroscientist at Duke, have had a project for many years looking at Fmri connectivity and activity changes after surgery. And what we found is largely that there's changes in one of the hub regions of what's called the brain's default mode network. To give a short, brief introduction to the default mode network, I would say One's brain is sort of like a stick shift car, if you can imagine. You can't really start a stick shift car in gear, and you can't go immediately from one gear to another. You have to go through a neutral state in between. Similarly, when we're thinking about, let's say, math, we can't immediately switch to focusing on what we're hearing. Sometimes people will say, well, hold on a second, wait, let me switch. It's almost like they're switching modes in their brain. And the default mode network is this network that's sort of on when the brain is doing nothing. Some people joke that it's sort of like a Seinfeld episode, a show about nothing, a brain network about nothing. But it's actually really crucial for switching between these different cognitive tasks. And what we found is that the default mode is dysregulated in patients with cognitive dysfunction after surgery, that it's on when it shouldn't be on and it's off when it should be on, basically. And we think that that's why perhaps patients with post-op cognitive dysfunction or perioperative neurocognitive disorders don't have one specific cognitive deficit. Some of them have a memory problem, some have an attention problem, some have an executive function problem. And we think that's because they're having problems switching between networks. And if you have a problem switching specifically into one gear in your car, let's say you can't switch into third gear, you might have trouble driving 30 to 40 miles per hour, but you might be fine at high speeds or fine at low speeds.
So do you think what people do at baseline affects that? In other words, the lawyer who comes out afterwards and says he can't prepare for court, is it?
So I think that goes in both directions. On the one hand, we know from many, many studies, our own groups and many others around the world, that preoperative cognitive status is one of the best predictors of postoperative cognitive status, not surprisingly. That's how most things in medicine work. So, the more active someone's brain is beforehand, and the stronger their cognitive function, the higher their level of educational attainment, the less likely they are to have cognitive dysfunction generally afterwards or delirium afterwards. At the same time, I also worry that some of the highest functioning patients are the ones who miss their cognitive function the most. I'm not sure that I'm high functioning, but I definitely feel like I need every synapse I've got. And I've had surgery now 4 times myself in my life. And at least the last 3, I've definitely noticed that I'm not quite as sharp afterwards.
So one of the things I talk about is the practicality of this. And, I'm thinking, well, maybe we just risk stratify and we do lumbar punctures and these scans on, your high-risk patients. But just like you said, it sometimes goes... It's the silent type of cognitive dysfunction.
It was interesting because I reported just last week, a friend texted me and said, my colleague went and had a surgery. They're now 4 weeks out. They think they've had a stroke or something has happened. They've had the complete workup. They're scared to death. And could this be the anesthesia? And, first you have to ask. But I said, funny you should ask. Thank God you asked me. Tell them that if they've really had the workup, they'll get better. Yeah. In all likelihood, because they're highly functioning. And that normalization, one of the questions that I think it came up to you was, should they do luminosity?
Well, that's what I was just going to ask, too.
Right.
We've been talking to American Heart, and I'd be curious. What we're hearing is... exercising, avoid excessive alcohol, avoid certain drugs.
Paul Wishmeyer nutrition.
Yeah.
Do all these prehab things.
That would be better, and I don't know if you...
I think those are certainly logical things.
Nobody studied it.
Yes, that's what I was about to say, is we need studies to really look at this.
Yeah.
There are some treatment studies and prevention studies for POCD. Actually, my mentor and chair, Dr. Matthew at Duke, has led a lot of those. They've done a large interventional RCTs, well-done studies, examining administration of different drugs during the surgery. Either they've done complement inhibitors to inhibit the inflammatory complement pathway in cardiac surgery. They've done magnesium and lidocaine as anti-inflammatory efforts. None of those, unfortunately, have worked, and those appear to be real negative results in large, well-conducted studies. They also did a study of an acetylcholinesterase inhibitor like Aricept, which is used for Alzheimer's disease. It didn't have a major effect on overall cognition, although it did appear to improve some specific domains. But I think Dr. Fleischer brings up a great point, and we need more studies to really look at what specific things help. Is it the same things that help for cognition generally, or is it more targeted things?
when we talk about what we can do as providers in the other areas of perioperative care, the Brain Health Initiative is addressing that, right?
Well, that's our hope. I mean, we've gotten multiple stakeholders, and what we think is important is, I think everyone's now agreeing we've got to inform our patients. I mean, that this could happen without scaring them, which is really why we partnered with something like AARP. We also need to inform our providers in the hospital, don't give them diphenhydramine post-operatively. I mean, there are things that, Miles and his colleagues and my colleagues at Penn may figure out how to do that may make it better, but there's a lot of things we do that make it worse. And let's make sure we don't do those things. I think the other thing that's really important is the caregivers for these people, that they should be aware that it's important not to, not to give them their keys back right away. If you
don't contribute to the problem.
Right. I mean, they may not be the same initially, but again, it'll get better. And just to be cautious. So I think that messaging to the provider community to say, talk about it and don't do the wrong things, and to the patient and caregiver community to know about it is our next goal over the next year.
Absolutely. That shared decision and bringing the team approach to care, not necessarily just with the providers, patient, family, everyone getting together. So, gentlemen, thank you so much for sitting down with us on Top Med Talk this afternoon.
Top Med Talk.
Nick Majerison here. Thank you for listening to Top Med Talk. Now, make sure you've subscribed to Top Med Talk on your podcatcher or however it is that you're listening to us at the moment. And you're spoilt for choice. We're on pretty much every single podcast platform you could think of. So make sure you've subscribed. Make sure you've engaged with us on social media, Twitter, Facebook, LinkedIn, YouTube. And make sure you've signed up for our email updates on topmedtalk.com. If you get yourself there, you'll find a website that contains all of the podcasts that we've ever done. And it gives you the chance to sign up for our email updates. That way we can always get in touch with you and tell you what we're up to. Oh, and while you're online, check out ebpom.org/meetings. While you're there, get excited about EBPOM London 2019, the London Perioperative Medicine Congress. It's on July the 2nd, and it's one of many meetings that EBPOM organises around the world in order to communicate the perioperative medicine message. Have a look, ebpom.org/meetings.